Alright. So we'll start off with the case. So we have a 45-year-old female, G2P1011, presenting with heavy vaginal bleeding times 2 days. Her heavy bleeding, she has some passage of clots. She was soaking 8 to 10 maxi pads daily. She had no dizziness, no chest pain, no dyspnea, fainting, or abdominal pain. Her review systems are notable for a flat crown, weight gain, an occasional sensation of complete voiding. Everything else was otherwise negative. Do you guys know why her review systems was significant? What does it tell you? For any?
Could be concerning for a large fibroid.
Great, perfect. So her OB history was just significant for an abortion and another vaginal delivery. Her guide history was just, she denied histories of STIs, fibroids, cysts, or abnormal pap smears. She hasn't seen a gynecologist in about 15 years since the delivery of her daughter. She thinks that her menses are becoming more heavy, but they still appear muscle. She's sexually active and has been using condoms for contraception. Her past medical history is just significant for hypertension, in which she's on metoprolol, and diabetes, in which she's using metformin. Her past surgical history is just significant for cholecystectomy. She has no allergies, and family history is she has no history of any gyn cancers or any bleeding disorders. So, do you guys know what the diagnosis is?
Abnormal uterine bleeding or threatening?
Exactly. Abnormal uterine bleeding, otherwise known as dysfunctional uterine bleeding. So what is abnormal uterine bleeding? It's basically menstrual bleeding that is abnormal or irregular in frequency, duration, or intensity. And it could be split, the etiology can be split between structural and non-structural causes. So the structural causes would be like polyps, adenomyosis, leiomyomas, malignancy, and hyperplasia. And non-structural causes can be coagulopathies, ovulatory dysfunction, endometrial dysfunction, iatrogenic, or not yet classified. To continue the case, her physical exam was significant for her tachycardia to 109. Her vital sign, her blood pressure was 145/89. She was static at 96%. She was basically well appearing in non-acute distress. She was A/O times 3. Her cardiopulmonary exam was benign. Her abdomen was soft, non-tender, non-distinct. Her pelvic exam was just significant for a 15-week size uterus, no adnexal masses. Her os was closed, had a 100 cc dark clot in the vaginal vault with oozing from the os, but no active bleeding on Valsalva or when she. Her ultrasound was significant for a 16 by 10 by 11 centimeter retrobuted uterus with multiple myomas, the largest one being 7 centimeters in anterior intramural lower uterine body, and a 4 centimeter one in the fundal semitotal myoma. Her ovaries were normal bilaterally, and her endometrium was distorted by the fibroid. And as you see here, her labs are significant for hemoglobin hematocrit of 6.4 and 18.2, creatinine was 0.6, and her coags were normal. So for physical exam and orders. So first, before we go into that, we just make sure that your HPI is good. Make sure that you understand if she's hemodynamically stable or unstable. Try to assess the severity and source of the bleeding. And for your initial laboratory testing, make sure you get a CBC to rule out anemia, platelet count, PT and PTT to rule out bleeding disorders, get a beta HCG to rule out pregnancy, and also make sure to get CMP or Untitled screen if you think the patient is really sick. For your pelvic exam and ultrasound, this can be used to identify any trauma from the genital tract or any vaginal cervical findings that can cause the bleeding. And it'll also determine if there's any uterine enlargement or irregularity, which could point to a sign such as fibroids. Next, you want to consult GYN. So what exactly would they want to know? First, they want to know if a patient is stable versus unstable. They also want you to quantify, quantify the bleed. So basically, how many pads has she gone through? If her pads are soaked or unsoaked, is there any clots? If she has any anemia symptoms, or if there's any active bright. Next, you want to go into the status of the labs. Have they been drawn yet? Are they cooking? What if they have results? Next, you want to ask about your clinical question. So here's basically where you say, hey, these are my differentials. This is what I'm thinking of. What should you do? Not that, hey, can you come down and do an ultrasound for us? Or, hey, can you come down and do an exam and see where it is? And then lastly, imaging. They want to know about the ultrasound, if it was done. So now we'll go into the bulk of what this talk is going to be telling you guys about, and it's a treatment. So you have some options here. So that, and they're listed in front of you. So first one is high dose conjugated estrogen, which would be given at 25 milligrams IV. The next would be combined OCP, which you can use any with at least 35 mcgs of ethinyl estradiol. The next option is Medroxyprogesterone acetate at 20 milligrams TID. And then your last one is TXA, 10 milligrams per kg IV or 1.3 grams per. And then I'll be going over each one of these separately. But before we go into that, how does estrogen-progesterone work for bleeding control? So in order to understand this, you need to know how they work endogenously. So the red box, the dark pink box represents the period. And after the period ends, the lining is at its thinnest. Over the course of the cycle, the endometrium grows, builds up due to estrogen increase, up to where ovulation starts. So once the estrogen peaks, the follicle releases an egg, and estrogen rapidly declines. If the patient is not pregnant, the corpus luteum involutes, and with it, progesterone declines. And as a result, the rapid decline in estrogen and progesterone will give you your withdrawal bleed, menstruals. So then, basically, to summarize, your estrogen promotes rapid regrowth of the endometrium, and then your progesterone acts as an anti-inflammatory, basically counteracting estrogen, and thins out and maintains your thin endometrium. So, why treat with estrogen? So IV conjugated estrogen is actually one of the only approved U.S. FDA treatments for acute uterine bleeding, and it's not widely clinically used though because of high risk of thrombosis. And again, I just want to point out how it should be used in unstable patients. Typically, these are poor surgical candidates, and it's actually best used in combo with other measures, such as IVF breast resuscitation, tamponade, uterine artery embolization. But again, should never be used as a long-term treatment. You always want to try to transition over to an OCP to prevent overgrowth of endometrium, leading to hyperplasia and cancer. Why should we treat with progesterone? You should use this only if contraindications to the estrogen-progesterone contraceptive or for a patient preference, and also minimizes risk of costs. Some contraindications include hormone receptor positive breast cancer, and basically your progesterone, it inhibits the endometrial growth, organizes and the existing endometrium so that it can shed more effectively rather than haphazard. Why treat with OCPs? So you can use OCPs that contain at least 35 mcgs of ethinyl estradiol, and it should be taken 3 times per day for 7 days. You can also take it as a dose pack, which would mean 5 pills day 1, 4 pills day 2, 3 pills day 3, etc., until you have one pill daily for at least a week. And this would cause bleeding to subside in most women within 48 to 72 hours. So just like the controversial topic of Mac versus Andy, which one is better? I would say. But anyway, no clear answer on which is better. Medical management should be your initial treatment, and your options includes the IV estrogen, multi-dose regimens of OCPs, oral progesterones, or TXA. And your decision should be based on the patient's medical history and contraindications to it. So for DISPO, you should admit your patient if patient's continuously symptomatic, if transfusions are required, serial H&Hs are required, and definitive surgical care is in. And for discharge, if you're going to decide to do that, you need to make sure that you have strict return precautions, which include bleeding that's greater than 2 pads per hour. There's large clots, headaches, dizziness, etc. And always make sure to refer to GYN for postmenopausal bleeding to work up ligaments. So I want to just leave you guys with some pearls. So first, do not use estrogen as a treatment of vaginal bleeding for women with breast cancer and those with high risk of cirrhosis. Progesterone is more commonly used as a treatment for vaginal bleeding over estrogen because it stabilizes the uterine lining and has a lower thrombotic risk than estrogen. Next, TXA was well studied in trauma literature and is actually now also frequently used for GYN and obstetric-related hemorrhages as a supplement to other methods. And you'll hear this referenced a lot because of the woman trial. And that's basically, it showed there were 20,000 women who were enrolled and randomized for TXA versus placebo. And it was found to be statistically significant difference in outcomes, specifically with death due to hemorrhage. And as a result, since then has been discovered to be a good adjunct for bleeding.
That's for postpartum bleeding, Harry, not for this.
Yeah. And then lastly, use OCPs as a medication regimen to send patients home with as a bridge to follow-up treatment. And this is really an underutilized thing in the ED and would be a great adjunct to give stable patients who are discharging with outpatient follow-up, as they should see resolution in their bleeding within, again, 48 to 72 hours. All right, so final thoughts, basically stabilization in your medical management. With stabilization, make sure you have your 2 large bore IVs, make sure you have some PRBCs ready, consult GYN, do a fast exam to just make sure there's no bleeding in the belly. And even think about using a Foley to tamponade if necessary. And for your medical management, again, it should be the initial treatment. Your options include your IV estrogen, your OCPs, your progesterone, and your TXA. And the decision should be based on the patient's medical history and contraindications to therapy. And once the bleeding episode has been controlled, transition the patient to some longer-term maintenance, such as OCP. These are my research. Any questions?
Yeah, a couple of questions and comments. One is I've sent home a few patients that weren't this bad, didn't have the manifest that low, but GYN has been very good about when you call them up and ask exactly which birth control pill they want, they will tell you and they will give you a follow-up and make sure that the patient is not sent away from the clinic. So I've always called them for this, just make sure the patient gets hooked up. That's important. The second thing is just off the track, but remember, this is not postpartum bleeding. So postpartum uterine bleeding coming from the uterus, again, remember you want to do a uterine massage and obviously your IVs and your blood, but there you're going to use your Pitocin, right? The different approach than you use here. Pitocin will work there because there's atleast.
Thank you.
Yeah, I also think like we get a lot of vaginal bleeding in our ER, and a lot of them are, I mean, they've been dealing with it for years, and they come in because it's frustrating. Like they're going through multiple pads, they can't really, their quality of life gets impacted. And I think having the conversation of starting something and different options is pretty helpful because a lot of times we'll check the hemoglobin, it's stable, and send them off with GYN and follow up without discussing like actual management of that bleeding. So I think this was a good introduction of that, but I think it's very helpful for the patient to at least give them the options because they're really there because the bleeding a lot of times is uncomfortable, aside from their symptomatic anemia if they don't have that. So giving them options is, I think, a good approach. So thank you for at least giving us that introduction.
I'll play devil's advocate and say a lot of your attendings will say they don't want to start OCBs because of the risk of clots and T's and B's. And while vaginal bleeding is not the easiest thing to deal with, it's also not that dangerous. If you go home and have a DVT or a PE and you die from it, that's the attending responsibility who started the pill. And I would tell you a lot of your attendings will not want to start it.
Progesterone.
Yeah, anti-exciting.
For that, I think with the higher utilization of progesterone, less of. I agree with Dr. Shamra. I often talk to the gynecology. I don't think they have to do an official consult, but just arranging follow-up with them and making sure that we're using the agent that they're going to put the patient on.
I think it's good to at least have the discussion with the patient and risk benefits just to see if they're into it. Because I mean, it at least will help them at least think about it before they even see.
Also, feminine products are expensive. If they're going through that many pads a day, it is like very cost prohibitive over time. So it doesn't kill the patient, but it can be very uncomfortable. On the flip side, I know our EDs, our attendants are less like advocate for OCTs. Do you know if other hospitals, like centers, are more apt to do so, or if you're familiar with your colleagues?
I'm not sure I've ever talked about it with people in other places. I know that many of us are the vast majority won't do it.
I think probably what you'll see in the community places more often is that more of the patients will have gynecologists. And so you would do the same thing as kind of what I would do here, resident, call the gynecologist and say, hey, your patient is here. What do you guys want to do? And you probably coordinate your care. And probably a little bit more medical legal there. You'd say, hey, I spoke to Dr. Smith, the patient's gynecologist, to see him tomorrow, starting prescription, whatever. So I think that's probably what you'll do a little bit more. And you may, even if they don't have a gynecologist, you may have a gynecologist on call pending for care. Where, it's not going to be a full consult.
Yeah,
I would also, it wasn't the scope of this lecture, but taking a look at some of the techniques and literature about packing uterus. The Foley is one way of doing it, but if you're in a place where you don't have gyne rushing to come help you, you have a patient who's in extremis, that's going to be a way that you're going to stabilize the patient. Because the estrogen, the blood will help, but you need to stop bleeding. So looking at how to pack uterus, give physical hemostasis.
I have a question for you or the attendees. Have any of you guys tried like the 5-day oral TXA regimen? Because like that's been shown apparently not to increase clot.
It's apparently very expensive as well.
Pricey.
Yeah.
No,
despite being like an old medication, like to the actual indication for bleeding, I was like, that was like crazy expensive.
That's good.
And you know what's funny? That an article just came out though on the use of TXA in GI bleeding, and they didn't find any benefit from it. Where it definitely seems to benefit GYN bleeding and trauma bleeding.
Only postpartum.
Yeah.
Only postpartum.
And I think probably the commonality is like this is an insult. And I think that's probably where TXA works the best, an acute insult. So I'm not, the good thing about TXA is all the literature shows really no.
Very little downside.
And it's cheap. Yeah, but I think the commonality between trauma and postpartum is that there's an insult to the body that's responsible.
Yeah, Dr. Hassel said that he echoed what you said. He tried it and it was difficult because the patient didn't have insurance.
I've talked with people at other places about whether they do these or not. It seems like the only ones that really a lot of from the ED are prescribing are progesterone, like solely based, which often probably isn't really the easiest one because shedding initially. So a lot of times they came in for bleeding, gave them medicine that causes them to bleed more, and then they stopped like taking it.
Mm-hmm.
So it's difficult sometimes.
Yeah. Any other questions, comments? All right, thank you, Harry.
Thank you.